All right, y'all, we are moving into section 2, and this is where the science gets juicy. We're talking about how HIV actually works, how it takes root in the body, messes with the immune system, and why that matters for treatment, testing, and vaccine development. Now, first, remember this. HIV is a virus, and not just any virus, it's a retrovirus. That means it carries its genetic material in the form of RNA, not DNA. Once it gets into the body, it doesn't just float around. It's got one goal: get into your immune system, hijack it, and turn your body's defenses into a viral factory. This retrovirus belongs to a subgroup called lentiviruses, which are known for being slow-growing. But slow doesn't mean weak. HIV is smart, persistent, and dangerous if left unchecked. The entry point for HIV is through certain body fluids: blood, semen, vaginal secretions, rectal fluids, or breast milk. Once it's in the bloodstream, HIV searches for a specific target, the CD4 plus T lymphocyte. These CD4 cells are the quarterbacks of the immune system. They coordinate everything. If you wipe them out, you break down the whole playbook of defense. So here's what happens next. The virus attaches to the CD4 receptor on the surface of the T cell. It uses a glycoprotein called GP120 to lock in, and it also needs a co-receptor, usually CCR5 or CXCR4, to fully enter the cell. It's like a double lock, and HIV has the keys to both. Once inside, HIV pulls out its secret weapon, reverse transcriptase. This enzyme converts the viral RNA into DNA. That new viral DNA gets transported into the nucleus and is integrated into the host's genetic material using another enzyme called integrase. At this point, the virus becomes a permanent guest. It's now part of the cell's own DNA. It can sit quietly or get straight to work making copies of itself. When it activates, it hijacks the cell's machinery to crank out more viruses, which are released to infect other cells. And just like that, the infection spreads. Now I want you to imagine this visually. HIV breaks into the control center of the immune system, rewires the whole system, and uses it to build more viruses that go out and infect even more cells. Meanwhile, your immune army is collapsing because its top commanders, the CD4 cells, are being destroyed from the inside. As the CD4 count drops and the viral load increases, the immune system weakens. That's when opportunistic infections start to creep in, things a healthy immune system would usually fight off without much trouble. But for someone with HIV, even a simple infection can become life-threatening. We classify HIV progression into stages based on the CD4 plus T-cell count. In stage 1, the CD4 count is over 500 cells per cubic millimeter. People may have no symptoms or just a mild flu-like illness. In stage 2, the count drops to between 200 and 499. This is where symptoms start showing up, maybe fatigue, skin issues, or swollen lymph nodes. Then comes stage 3, when the CD4 count drops below 200. That's when the diagnosis officially becomes AIDS. At this point, the immune system is severely compromised, and the risk of opportunistic infections or cancers increases dramatically. And here's a little detail a lot of folks miss. Once someone has reached stage 3 and been diagnosed with AIDS, they don't get reclassified back to stage 2, even if their CD4 count improves. That AIDS classification stays on their medical record permanently. Why? Because it impacts long-term services, insurance coverage, and support eligibility like housing or food assistance. So let's move into testing. There are 3 major ways we test for HIV. First are the antibody tests. These detect the body's immune response to the virus, not the virus itself, but they can miss early infections. Next are the antigen-antibody combo tests, which can detect both HIV antibodies and something called the P24 antigen. This shows up earlier in the infection. These are faster and more accurate than antibody tests alone. And finally, we have nucleic acid tests, or NNATs, which detect the virus's RNA directly. These are the most accurate, but also more expensive tests, so they're not used for routine screening. To figure out how recently someone was infected, we use an algorithm called STARHS. This helps us detect early seroconversion, the window between exposure and the body developing a detectable antibody response. When someone tests positive, we always confirm the results with additional tests. These include a differentiation assay to distinguish between HIV-1 and HIV-2, and RNA testing to measure the viral load. And for patients newly diagnosed, or those re-entering care, we also do resistance testing. Because just like bacteria, HIV can mutate and become resistant to medications. And that brings us to something called anti-retroviral therapy resistance, or ART resistance. This means the virus has figured out how to survive even when medications are present. There are two major reasons this happens. First, the person might have been infected with a drug-resistant strain of HIV from the beginning. That's called transmitted resistance. Second, resistance can develop when someone is already on ART, but the regimen isn't fully suppressing the virus. That's called selective resistance. To figure out what we're dealing with, we use resistance testing. Genotypic assays look for specific mutations in the virus's genetic code, basically checking if the virus has developed armor. Phenotypic assays go a step further and test how well the virus grows when exposed to different drug concentrations. Genotypic testing is preferred because it's cheaper, faster, and easier to interpret. If someone delays starting ART after testing, we usually repeat the resistance test before starting treatment, just in case they picked up a new resistant strain in the meantime. Now let's shift gears into a complication we really need to keep our eye on, something called immune reconstitution inflammatory syndrome, or IRIS. IRIS is what happens when the immune system starts bouncing back too quickly after starting ART. The immune system regains its strength and suddenly starts attacking infections that were previously hiding under the radar. So instead of getting better right away, some people actually feel worse at first. IRIS usually shows up within the first few months after starting ART. It's linked to a bunch of infections, but the most common ones include mycobacteria, herpes viruses, and deep fungal infections. The symptoms can include fever, cough, abdominal pain, and a flare-up or worsening of previously treated infections. It can be scary, and in some cases severe enough to require hospitalization. We usually treat it with anti-inflammatory meds like cortisone, but the key is catching it early. Nurses and providers need to be alert, especially during the first 3 months of ART, because this syndrome is tricky and can mimic other problems. One special form of IRIS you need to know about is TB IRIS. This happens in patients who are being treated for both HIV and tuberculosis. When ART kicks in and the immune system starts to wake up, it reacts hard against the TB bacteria, even though the patient is already on TB treatment. Most cases happen in the first few weeks of starting ART, but it can occur later too. TB IRIS is more likely in patients who had low CD4 counts when they started therapy. We don't fully understand the science yet, but it looks like the sudden surge in T-cell function plays a big role in triggering this inflammatory overdrive. All right, deep breath. That's where we'll stop for now. We've covered how HIV takes over the immune system, how testing and resistance play a role in care, and the complications that can happen when the body starts fighting back. In the next section, part 3, we'll look at the clinical manifestations and what you can expect to see across body systems when HIV really starts doing damage. We'll talk symptoms, opportunistic infections, and what nurses need to recognize at the bedside.